Okay, thank you for joining us tonight for the GP immunisation update. I'm Ali Sullivan and part of the education team at the Western New South Wales Primary Health Network. I'd just like to start the meeting by acknowledging that we're meeting tonight on Wiradjuri land. I pay respect to all elders, past, present and future, and acknowledge their continuing connection to land, water, culture and community. And thank you everyone for joining us on the webinar tonight. Just a few little housekeeping. We'll have the Q&A box if you any questions in there, and we'll stop throughout the presentation for Nick to take any questions from that. We've got everyone on mute. We're also recording this session. After the Q&A, Dr. Amanda Brownlow will be doing an update on health pathways and in particular the immunisation pathways, and then there'll be an evaluation form after the session. So I'd like to introduce Professor Nick Wood. Nick's a staff specialist general paediatrician and a professor and sub-dean in the discipline of child and adolescent health at the University of Sydney. He's an associate director at the National Centre for Immunisation Research and Surveillance. And Nick, thank you very much for being here tonight, and I'll hand over to you.
Great, thanks very much. I'll just share the slides. Hopefully that is projecting okay.
Yeah, thank you.
So hi everyone, thanks for joining on a Thursday evening. So what we'll do firstly is acknowledge country and pay respects to Aboriginal and Torres Strait Islander people joining us tonight, and elders past and present. So what we'd like to do in the next little while, I was saying to Amanda just a minute or so ago, there's a fair bit of slides here, so we can make all of these slides available for the group via the PHN after the talk. So it's a fairly rapid tour through some of these topics here. We might pause as we go along for any questions that pop in, and hopefully gives time for you to ask some questions at the end, which either if I can't answer, I'll try and get the answer back to you via the PHN as well. So where are we at with winter viruses? The two things that are circulating right now, which you're probably experiencing in your clinic, there's a bit of an uptick in COVID. Flu, not yet sort of ramping up, but certainly in the hospital environment, we've been seeing a fair bit of RSV. And I suppose the other one, which you're definitely seeing, is mycoplasma in the community environment, because we're certainly seeing it in the hospital. So COVID and RSV are dominant, and that's often the way with RSV, that it tends to come before it gets pushed out by flu. Okay. Last year's flu season, people often say, well, how effective was it? Pretty good match in terms of the antigen components to what was circulating. And you can see here that the vaccine effectiveness was sort of on par with what we normally see, around about 60 to 70% effective. So that's the usual sort of story. So if people ask how effective was last year's flu, or you can tell them that based on what we know from last year, about 70% protective against hospitalisation, which is pretty good. The TAGI has a statement on the use of the seasonal influenza vaccines, which is available, but it's the usual story, nothing really new. It's funded and recommended for kids aged 6 months to less than 5 years, and for all adults over the age of 65. And then for those who are between 5 and 65, it's funded for those who have at-risk conditions. And I think we show in the next slide, but that's Aboriginal and Torres Strait Islander, certain medical conditions and pregnancy. These are the vaccines that are available on the program, depending on the age. That's under the NIP. And you're probably busy giving out the flu vaccine. So nothing terribly new there. This is the list of conditions. I was saying to the nurses earlier today when we talk to them in orange, that one of the things I like to think about when we see people in front of us is the HALO principle, which is HALO, and that stands for health, age, lifestyle, and occupation. And so if you've got someone in front of you, think about their health, their age, their lifestyle, and occupation, and whether or not they need extra vaccines. And this is the list of health conditions which might provoke an additional flu vaccine recommendation. How are we doing with coverage? Well, we could do better. This is the current figures. You can see nationally, even though the program is free for 6 months to 5 years, uptake to date not been crash hot, about 14%. Doing a bit better in the over 65s. We're hitting the sort of 50% mark nationally. Probably doing not as well in our Aboriginal and Torres Strait Islander population in the younger kids, but reasonably okay in the over 65s. So there's a little bit of work to do there. I'm interested to hear some thoughts from folk perhaps later on about what they think is perhaps driving lack of uptake. There are now 2 types of flu vaccines available. So there's the cell-based, which is the new kid on the block, and the egg-based vaccines. The advantages of the cell-based vaccine is that because we don't need to grow the virus in the eggs, there's a shorter production time, and it means we have less reliance on eggs, less dependence on the eggs production, and better production overall, but that is more expensive. So that's probably the biggest issue. In terms of the vaccine for which there is the cell-based one, you've got Flucelvax Quad there, and you can see it is available for all ages. But in terms of the NIP, it's really only under the NIP for the more than 5 to 65 who have certain risk conditions. In terms of comparison between the cell-based and the egg-based vaccines, either is available and either can be given. There's no sort of added margin or benefit of one over the other. Even those kids that have egg allergy, they can still have not the egg-based vaccine, so they don't necessarily have to have the cell-based vaccine. So this might be the way of the future, that we move to a system where they're all cell-based, because, as I said, it's a little bit easier on the production side. Okay. For COVID-19, we're learning to live with COVID-19. This shows you the sort of circulation of the virus. Little bit of an uptick throughout May and into winter, which I mentioned earlier. This is a graph showing you the changes of the variants over time from August last year through to May. The XBB variant has sort of disappeared a bit now and has been replaced by the JN, and now being replaced by the new variants KP and KW. So I don't think we're going to be in a position to really chase the variant changes too much with the vaccines, which we were trying to do, but it'll be a matter of using the current brands and aiming for cross protection. So the COVID vaccine is recommended every 6 to 12 months for those who are the older adults. You can see there that the over 75 should get a dose every over 75 years should get a dose every 6 months, even if they're with or without immunocompromise. For the 65 to 74 years, there's the note that they probably should try and get an annual dose, would be my summary on that one. And then the 18 to 64s, if you've got immunocompromise, again, probably at a minimum a dose every 12 months. So we're probably moving into an environment where the over 18s, particularly over 75s, get a 6 monthly dose. Between 18 to 64 years, just try and get an annual dose. As you can see there, the under 5 years not recommended, and between 5 to 17, really only those kids who have immunocompromise. This is the list of some of the immunocompromised conditions, which I won't go through because it's for time purposes, but this is all available in the handbook. But it's a similar story for what we use for the flu vaccine. So who doesn't need a COVID vaccine? Kids under the age of 17 who do not have any immunocompromised, but even though they've not had the primary vaccine series, they still don't need to get a vaccine. And the reason for that is that we know from sero surveys that pretty much everyone under the age of 17 has been exposed to SARS-CoV-2, and because we're detecting that in the sero surveys that we've been doing nationally. We also know that the risk of hospitalisation in this age group is pretty low. Adults over the age of 18 who have never had a previous vaccine should get a single primary dose. So even though the risk of hospitalisation is low, because they've never had a dose, we probably should just give them a booster, even though they've probably had natural infection as well. Moving on to RSV. As I said, RSV is circulating right now. We've known about RSV as a burden issue for us for many decades. The key groups that this graph is trying to highlight, which you already know, is that the high hospitalisation rates are in the under 6 months, and more so in the Aboriginal and Torres Strait Islander compared to the non-Aboriginal and Torres Strait Islander, and also ticks up in the over 75s here. This change will basically, because of the ability now to do sort of testing more available, particularly in the hospital environment, and also in primary healthcare, we're counting the RSV cases better than we ever did before. So the bottom line here is that you already know that the younger kids and the older adults are at high risk of RSV, particularly hospitalisation. The other thing is that RSV infection early in life has ongoing issues. And this slide here shows that if you do have infection during infancy of RSV, you're more likely to end up with asthma, and particularly with non-atopic asthma, compared to children that have never had RSV. So that's one of the longer term impacts of having an early RSV infection. So if we can do our best to prevent early RSV infection, we may well have an impact on future asthma. So because of the high burden and because of the issue of longer term effects of RSV, there's been a lot of attempts to try and prevent it. So we now have 2 vaccines. We have a Arexvy and a Brisvo. And we also have the long-acting immunoglobulin called Nirsevimab, or the trade name is Beyfortus. So I'll tell you a little bit about each of these. The target that we're trying to prevent RSV is to make sure that the body has neutralizing antibodies against this RSV pre-F protein, pre-fusion protein. And the site there is this site 0, and that's where the Nirsevimab, the antibody, basically is against this site 0, and the vaccine leads the body itself to make antibodies against this pre-fusion protein. So that's the key goal of the vaccine. So ATAGI has issued some statements on the use of Arexvy, and we can we'll go through that. Arexvy is registered in January this year. It's for use in those over the age of 60. It's a single intramuscular injection, and you can see here that this is from the clinical trial data, with about 12,000 participants who got placebo or the vaccine. And they looked at the incidence of RSV-related lower respiratory tract, and you can see there was a definite reduction in RSV disease in the vaccinated group. However, in the trial, there was noted a couple of adverse events of special interest. So there was 2 things from a neurologic side, or actually three events in the neurology. There was some inflammatory condition. So there was case of Guillain-Barré syndrome and 2 cases of ADEM. And there was also a little bit of a mismatch between cases of atrial fibrillation in the subjects that got vaccinated compared to the control. So both of these side effects have been listed in the product information, and there'll be things that are actively being monitored for. So your sort of job, I suppose, is one to, if we'll talk about it in a minute, but if people do get the Arexvy, the Arexvy vaccine, and they do have a side effect which you become aware of, then it's important to report that. So this is an attempt to sort of outline the risk and benefit. And you can see here with Arexvy that per million doses of Arexvy, we will prevent 23,000 outpatient visits, about 2,500 hospitalizations, some ICU and deaths, and we'll probably be seeing, if the risk based on the trials, about 10 cases of GBS. So that's that whole risk-benefit profile that we look at when we try to go to license these vaccines. So Arexvy is available only as a private script. It's recommended for those over the age of 75, as I showed you from the graph earlier. That's where the risk of hospitalisation goes up. For Aboriginal and Torres Strait Islander people aged 60 to 74, and those aged 60 to 74 with the medical conditions, and it's pretty much the same medical conditions that increase the risk of COVID or flu. But it is on the private market, and it is quite expensive at, I think, around about $300 a dose. So one day I suspect it will make it onto the National Immunisation Program. This is the list from the ATAGI statement, which is very, very similar to the list for COVID and flu, so we won't go into it. But again, think of the halo principle: health, age, lifestyle, occupation, anything in the health from the chronic conditions that puts people at risk. So what about protecting young infants? What are our options there? So there's a bit like we try to protect young infants from flu and whooping cough. There's the vaccination during pregnancy, and the vaccine that we'll be using in this space is Brisvo. Arexvy, which was the GSK product, which is approved for use in adults, is not to be used for pregnant women. There was a risk of premature births, and the phase 3 trial stopped. So Brisvo is the vaccine. From the clinical trial where Brisvo was given to pregnant women, you can see here that the vaccine efficacy for the first 90 days of life against severe disease was pretty good, around about 80%. It fell away a little bit beyond that time, out to 180 days, but still some reasonable protection. For non-severe disease, it was a little bit less at 57%, but still not too bad. The Brisvo given to pregnant women was very well tolerated. However, similar to the Arexvy, there was a trend towards premature birth, but this was not felt in the analysis to be sort of significant to certainly halt the trial. But it's something that I think we'll have to watch. There's no inflammatory neuropathies or atrial fibrillation as we saw with Arexvy. And infants who born to mothers who were vaccinated did not have any increase in allergies as well. So it's quite well tolerated. So Brisvo is recommended and registered at these age groups in the US, UK, and European Union. It can be so around about that sort of 32 to 36 week mark gestation. It can be given at the same time as the other pregnancy vaccines like DTPA and influenza. No problems with adverse events when you give them together. And there have been some studies that have looked at the antibody responses when they are given together, and not really any significant difference in the immune responses when it's given together with, say, DTPA. So that's a Brisvo. The long-acting monoclonal antibody is called nirsevimab or Beyfortus.
Okay, there's a dose here which is 50 milligrams for infants under 5 kilos. It's a monoclonal antibody. So rather than giving the mother the vaccine and asking her to respond to the antigen and make antibody, what we're doing here is actually giving the infant the antibody. You may or may not have used palivizumab, which is the sort of forerunner of this antibody approach. It required monthly injections, and the key advantage to this product is that because they've been modifying part of the antibody, they've been able to extend the half-life. And so that's why it can give you protection for a single dose rather than the monthly dose. So a single dose can give you protection for an RSV season. So this is information from the vaccine trial. You can see they're not huge numbers, about 4,000 kids. But importantly, there was an 83% reduction in hospitalisation. So it was very, very effective in reducing infants. So we've now got this. Eventually, we'll have, not this year, because Abrysvo is not yet in the country, but at some point in the future, we're going to have the products Abrysvo for pregnancy vaccination and the Sivimab for neonatal and infant vaccines. And we'll be working out which way to use both of those products. There is now some real-world evidence from a province in Spain. This particular, I think I'm not sure I've put it there, but this particular province was able to have a very, very high uptake of the Nirsevimab at birth. Yeah, you can see there was about 92% coverage, which was quite extraordinary in that province of Spain, and then 80% catch-up. And then the graph shows you the impact on hospitalisation. So the lines refer to previous seasons, and the purple line is the season 2022-23, and the orange bars are the 23-24 season. So in this particular province, where there was a lot of infants who were able to be given the Nirsevimab, there was definitely an impact with reduction in hospitalisation. However, there is a global shortage of Nirsevimab, and there has definitely not been a national strategy for Australia. It is available for infants in Western Australia and Queensland, and I'll show you in a minute, available only for vulnerable infants in New South Wales, but is recorded on the immunisation register. So these are more detail about which state programs. Probably of interest to you guys is the New South Wales program, which will be started in March and will run through to September or whenever they use all the doses. It's a targeted program, so they're targeting premature infants, First Nation children, and then other vulnerable infants who are really those that have sort of got chronic lung disease or got an oxygen requirement. So, and it's being delivered mainly through the public health, through community clinics, and through the hospitals. It's not, Nirsevimab is not available on the private market. Ultimately, we will be giving it to infants, I suspect, next year, and we'll come back and update you. But what we know right now is that if we wanted to give it at the same time, which is probably what they're doing in some of the hospital environments, as say the 6-week vaccines, there's no increased risk of adverse events. It's actually a very safe product, very, very minimal reactogenicity. I won't spend too much time on this one, but actually there's a question that's just popped up there. Yeah, so this was a question about mother of a 3-year-old who'd been hospitalised with RSV multiple times, and is there a role in older children? Mum is very happy to pay privately. So unfortunately, Mum won't be able to buy it this year because it's not available on the market, but probably won't be ultimately available for that age group indication anyway, because it's the main goal of this is to stop hospitalisation, and most of the infant hospitalisation is in the under, as I showed you earlier, is in the under 1. So unlikely that a 3-year-old will be
admitted with RSV, even though they've had multiple things. So probably not in that particular case. And how long is protection? Another question. How long is protection from Arexvy expected to last? That's an excellent question. I think I showed it here. So I'll just go back. Where was it? No, I didn't show it, but it's probably it'll be a good question, and we haven't been using it long enough yet to answer you. But it probably will be at least one season, but probably a couple of years. So the US is looking at it right now, and so they're giving many more doses than we are. And so they're ahead of the curve, if you like, and they'll be able to help us answer how long Arexvy lasts. Can't see any other questions there. Oh. Nope. And then I think not much to say about Vaxelis and not sure if anyone's using it, but it is the alternative vaccine to Hexa. The benefit of it is that it already comes in a pre-filled syringe, and therefore no reconstitution is needed. It can be given interchangeable with Hexa, although we don't really recommend that. But if someone's had 2 Hexas and they come up and you don't have any Hexa, but you've got Vaxelis, you can give that. If they've had, say, 2 Vaxelises and they come to you and you haven't got any, you can give Hexa. So it's okay to do that. And it can be co-administered with other vaccines. Okay, so herpes zoster, you will know what it is and how to treat it. We do have a recombinant vaccine, which is Shingrix, using this new adjuvant system from Shingrix, from GSK rather. It's registered from 50 years of age. It's a 2-dose schedule. The gap between dose 1 and dose 2 is somewhere in the interval of 2 to 6 months, okay? However, if the people are immunocompromised, you should try and get that second dose in a little bit earlier. Shingrix is funded on the NIP to the people listed here, over 65s, First Nations people, and then again immunosuppressed. In terms of the real-world effectiveness, pretty good. So this forest plot here shows different studies and different ages. More effective and in older. So it's more effective in younger people compared to older people. But overall effectiveness is around about 70 to 80%, which is not bad for a vaccine, particularly as it can protect you against Shingrix, which we all know can be very, very painful and cause a fair bit of morbidity. 2 doses is more effective than 1 dose. In terms of some practice points for you guys, if someone says I've already had shingles, should I get a dose of Shingrix? We know that recurrent Shingrix can occur, and it usually happens. The risk estimates are about recurrence rate about 5%. A little bit more likely in immunocompromised. But if someone wants to have a Shingrix and they've had shingles before, we would suggest waiting for about 12 months after that shingles event before you give them Shingrix if they're immunocompetent, and perhaps a little bit less time if they're immunocompromised. If someone's already had Zostavax, can they have Shingrix? The answer to that is yes. And again, we suggest you wait about 12 months after the Zostavax. Do you need to confirm that a person has had previous chickenpox before you give Shingrix? The answer to that is no. Nearly everyone over the age of 30 will have had chickenpox at some point in their life, so not much point doing the serology. If a person, we said before that the interval between dose 1 and dose 2 for immunocompetent people was around about 2 to 6 months. Excuse me. If someone turns up at sort of 7 or 8 months after they've had dose 1, don't need to restart the schedule. I think you can just carry on and go dose 2. And I'd probably extend that out to around about the 1 year, 1 to 2 year mark. We haven't been using it long enough to say that the interval, what is the actual interval where you need to restart the dose, but I reckon you could go out to sort of, as I said, the 18-month mark between dose 1 and dose 2 and just finish the schedule rather than restarting. Just to remind you, as you already know, the HPV vaccine is now a single dose. So that's just a reminder there. A pneumococcal. Now the changes in the pneumococcal, which is always difficult because we keep adding different valencies to the situation, makes it hard. So now we have in town 15 valent, 20 valent, and a new one which is not yet registered, which is a 21 valent vaccine. So you know, we started off years ago with Prevnar 7, then we went to Prevnar 13, and now we've got 15 valent Vaxneuvance and Prevnar 20. The Vaxneuvance and the Prevnar 20 are registered. They have received a positive recommendation from the PVAC, but they're not yet on the NIP, and that might be what happens. My guess is that we'll probably what will happen is that the schedule will sort of look like this. Particularly for kids, will be given the options of either the 13, 15 or 20 valent Prevnar as an infant. And then for the adults, if you're over the age of 70, you'll probably end up, I suspect, having the 15 or the 20 valent one as a single dose. If you're an Indigenous adult from 50 years and onwards, you'll get this sort of schedule, single dose of 15, 13 or 20, followed by the PPV. And if you're over the age of 18 with special risk factors, you'll either, again, you get a single conjugate vaccine followed by a PPV. So, so what's important is that you get a conjugate vaccine in, basically. And it can be either 13, 15 or 20, but at the moment, 15 and 20 are not funded. We don't really have vaccine efficacy on the 15 and the 20 valent one, because the trials need to be enormously big to look at impact on invasive pneumococcal disease. So what they tend to use is immunobridging studies. And so if the vaccine, like the 15 or the 20 valent one, can show in a head-to-head study with the 13 valent vaccine that it's able to produce the same amount of antibody levels, then they can license it based on the antibody levels, if that makes sense. So they won't be able to show the vaccine efficacy. They'll just use the correlative protection, which is an antibody level. And if 15 and 20 valent have similar antibodies to the 13 valent in the common serotypes, then they'll say it's immunologically equivalent and therefore can be licensed. We are seeing a bit more pneumococcal disease now than we have before. Most cases are in the edges of life, over 65 and under 4. And the 3 serotypes that we are seeing are in the 13, 15, and 20 valent vaccines. So either any of those will cover the 3 common serotypes. So I think I've sort of charged through this fairly quickly, but I'm hoping to have plenty of time for you guys to ask questions. One of the things that we are seeing is a general trend to vaccine fatigue, if you like, and hesitancy in the community. And I was talking to the nurses earlier today. This is a bit of a worry. It's a bit of a crossroads for our immunisation program, because we are seeing a reduction in coverage, not a huge amount, but 1 to 2% in some areas, even more so in our Aboriginal and Torres Strait Islander people. Now, that's just not an Australian phenomenon, it's a global phenomenon. And that means, unfortunately, that we will see a resurgence of diseases that we didn't really see so much before. For example, measles, and we are seeing more and more whooping cough around. So it's a bit of a crossroads really, and GPs and nurses and pharmacists are trusted providers. You guys can help influence the uptake to stop the slide in coverage. I don't know if there's a single one answer to how we stop that. And there's probably many reasons as to why it happened. I suspect people are just sick of hearing about vaccines because of COVID. I think there probably was a bit of a mistrust in that the policymakers keep saying you need to get a booster, you need to get a booster, but people still getting COVID. So they're thinking, well, the vaccine's not really protecting me against the COVID disease. So, you know, what's happening here? So I think there's probably a range of reasons as to why there is some hesitancy. But it is a bit of a worry. And so there's lots of resources that people are working on. This is one here about Aboriginal and Torres Strait Islander people and how to improve conversations or support conversations. We also have this is sort of a talking guide about how to do it. We also have this, which we've presented to you before, the Sharing Knowledge About Immunisation webpage. And that's really useful, not only for healthcare professionals, but also for the public to go and have a look at. These are some older webinars as resources. These have all got recordings, except for the bottom one there, but the top two have recordings. So if you've got time and interest, you can log on to the NC's website and have a look at those webinars. So yeah, so Amanda, that's been a fairly speedy tour. I wanted to leave time for question and comment. So this is there's one here I can see in the chat which says, I have a patient who's adamant that she's never had chicken pox. Does she need Shingrix? Sort of depends on the age of that person, Jennifer. So like I said, you know, pretty much anyone over the age of 50, certainly, and probably over the age of 40, has been exposed in their life to wild type chickenpox. Even though they don't remember it, they may have had a subclinical or a silent low-grade infection with a rash at some point. But if they're interested and they're of an older age group wanting to protect themselves from Shingrix, from shingles rather, then yes, I would. They don't need to do serology. Serology sort of won't really help you. You can give that Shingrix vaccine. Yeah, so I know I've sped through that, Amanda, but I was keen for to hear from the group if what we see in the data about declining coverage is mirrored out there at the coalface with people saying, well, I'm sick of hearing about vaccines. And I think the important thing to remind people is that, yes, there were some high profile adverse events reported after the COVID vaccines. And, one obviously the one is the clotting, the TTS, the thrombosis thrombocytopenia that followed the AstraZeneca product. And there was also the myocarditis that has appeared mainly after dose 2 of COVID, and particularly in young males. But, there have been no new safety concerns with the NIP vaccines. The ones that we've been using now have been unchanged really for more than a decade, particularly in the infant schedule. So, Infanrix, Prevnar, Rotarix, MMR, MMRV, DTP, those vaccines all in use up to the age of 5. There's nothing new in terms of safety signals. They remain as safe as they always have been. So I don't know if people are sort of saying, oh, they're lumping all vaccines as bad, and that's impacting them. So, but yeah, nothing new at all from the safety concerns in the old established product. So I'll stop there and see if we've got any questions or comments from the folk.
Thanks, Nick. That certainly has been. It's always fascinating, I think, to hear and important to hear the numbers and the data behind decisions and where things have come from. And I definitely would encourage anyone, if you've got any questions, to either pop them in the chat, or are people still able to unmute themselves if easier? No, in the chat, folks.
So I think what we'll face in the future is, particularly with the RSV protection, my guess is that, we'll have a Brisvo, which is registered. We'll have product available in the country, supposed to be coming sort of June-ish. We'll have a scenario where pregnant women get a Brisvo, the RSV protection, and the infants born to those women don't get any nirsevimab. It might well be that infants born to mothers who did not get a Brisvo do get nirsevimab, and it might be that premature infants also get nirsevimab. So we'll work through that. Atagi's looking at that sort of nowish, but it won't. The RSV season will probably start to run down as we move into flu. So I can see Jennifer's asked a question about what's the latest with Q fever vaccines, especially in regional and rural areas. Again, the vaccine has not changed, and it's still, the same old vaccine. It is unfortunately a costly vaccine, and it does require the two-step process, so the screening followed by the vaccinating. We are doing a Q fever vaccine trial where we're trying to recruit kids aged 10 to 14 years. So if might send via the PHN a flyer that you could possibly, do some spruiking or recruiting for us. We are hoping to be able to set up a functioning trial site in Western New South Wales, where parents of kids who they want to get Q fever vaccine can come along and get it for free. I know there was a question earlier today about will there be made free Q fever vaccine available, and the answer to that is I don't think so. So then there's a question from Kate about, which is a good one, and I'd be lovely to hear your thoughts as people at the coalface. Pregnant women now get Boostrix and flu. What about RSV vaccine? I suspect it will be available in the GP land. But what is interesting is will a pregnant woman have flu, RSV, and Boostrix? I'm not sure we know the answer to that, particularly when we want to get them all in between, ideally before 30 weeks gestation. So there's three vaccines there, particularly in the flu season. But I suspect they will be available in the public place via GPs. Interested to hear thoughts from the group on that one. And question from Mark about can Fluvax and Shingrix be given together? And yes, the answer to that is they can be. Shingrix is a fairly reactogenic vaccine. I remember my father getting it and thinking, "Oh my God, what have you given me?" He said it was worse than the COVID shot, with some headaches and malaise, bit of a sore arm, but he felt a bit sort of, a bit groggy for a couple of days. So Shingrix is fairly reactogenic. So important to remind people about that. But yes, you can give them together. If they don't want it to have it together, you can separate it by sort of a few weeks. Comment in the chat. So Emma asks, when do partners of expectant mothers need an additional whooping cough vaccination? That's a good question. So I think if it's a 30-year-old male whose previous dose was, say, as a teenager, I would give that partner a Boostrix whilst his wife or partner is pregnant. That makes sense. So the partner, if they've not had a dose in the last 10 years, I think they probably would benefit from one. Again, it's not funded, so you have to pay for it. If they've had a dose of the DTPA recently because their partner was pregnant, say 2 or 3 years ago, then no, they don't need to have a booster. However, we do know that we need to give the pregnant woman a booster every time she's pregnant. So the reason for giving the pregnant woman the booster is mainly because she herself makes antibody, and by getting higher antibody level in the mum, it will cross into the infant, neonate, and then into the infant, so that the baby starts life with a good amount of infant. So I thought there was, so Jennifer asked about flu and COVID vaccines together. They're adjuvanted and they need to be 2 months apart. No, so not the flu and the COVID. So there is, in the over 65s, the flu vaccine, there is Fluad Quad, which is an adjuvanted flu vaccine. None of the COVID vaccines are adjuvanted. Shingrix is, as I said, a bit more reactogenic. So, an adjuvanted flu vaccine together with Shingrix, you might see some sort of systemic side effects. So if there's any concern, then you could certainly separate them. Probably doesn't have to be 2 months, but you could, yeah. So Jennifer's saying Shingrix, yeah. So I think we had a statement earlier comments about Fluvax or Fluad Quad and Shingrix. There's not much data on that combination of giving them together. If it's an opportunity where this person will only be there once and then they're disappearing for 6 months, I think you could give them together, but just remind them or warn them that this combination is a little bit reactogenic. And so if they don't want to have that sort of feeling a bit achy and malaisey and headachy sort of issue, then you could certainly separate them probably by about a month would be fine. So hopefully that's answered that one. Right. Any other?
Thanks, Nick. That was great. If there's any more questions, just keep putting them in the Q&A. I'll ask Dr. Amanda Brownlow now to talk about the health pathways. Amanda's a GP VMO within the New South Wales LHD. She's currently the medical lead for the Care Partnerships Diabetes Collaborative Commissioning Project that's running across our PHN footprint. Amanda's also the GP clinical editor with the PHN health pathway teams and has previously worked closely with the Hunter New England health pathways team. Prior to Dubbo, she was a GP with the RFDS in Broken Hill. Thank you, Amanda.
Fantastic.
Stop sharing and you can go. Thank you.
All right. Thanks, Ali. Can everyone see that?
Yes.
Right.
Yes.
Fantastic. Thanks again, Nick. It is so good to have the opportunity to ask those questions and to have that understanding. This vaccination is a constantly changing landscape, isn't it? And so one of the questions is, how do we keep abreast of it in clinical practice? Obviously, sessions like this are crucial. And so is a live source of information. So this is definitely a plug for Health Pathways. For anyone who's not aware, and an introduction to our Health Pathways suite for vaccination. Just happened to be a really good opportunity to do that. For those who aren't aware, Health Pathways are essentially a living guideline. They're for use at point of care. And I'm really lucky, as Ali said in that introduction, I used to work in Hunter New England, who've got a really mature suite of health pathways, and I cheered when I discovered they were coming to the Western New South Wales area as well, because I think they're such a great resource. If you've not registered for access, please do. Currently, just drop Marianne a line, find this link on the PHN webpage. Currently, the login is generic. You know, someone in your practice may already have it. What is coming down the track are individual logins. I won't speak too much about that now, but it will capture the opportunity to garner CPD points from your use, because you can track what you're seeing, which I think is a really excellent opportunity to gain CPD for what we're doing in our clinical practice day by day anyway. When you log into Health Pathways, this is where you land. It's our Health Pathways welcome page. And I point this out because one of the really great features is actually this section in the middle here, just under latest news, where we publish recent updates both to Health Pathways and other updates, such as, as we just heard tonight, the changes to the shingles vaccination and COVID vaccination updates. So this is a great source of recent news that's relevant to clinical practice immediately. The other thing, of course, we find in our welcome page is our list of contents. And this is fairly standard across the Health Pathways. For people who may not be familiar, Health Pathways itself is a program that's come out of New Zealand. There's lots and lots of work being done across New Zealand, Australia, and the UK around developing this as a program. It continues to evolve and change. What we are doing here in Western New South Wales is, as we are writing our Health Pathways, we are sending them live so that there's no delay. Other areas have chosen to do a year or so's worth of work to get their Health Pathways filled in before they launch them. We've not taken that option here. What that does mean, though, is that you will see lots of things that are still greyed out because we haven't gotten around to localizing the pathways that are there. Okay, we're not a very big team, and we are working hard, but there's a lot of work to be done to bring these up to our to make them locally relevant for us. If I pop in here to now I happen to know where the vaccination suite is kept, but if you didn't, you could certainly pop up here into Health Pathways and honestly type something sensible, whatever you're looking for. It might be vaccination, it might be immunisation. You don't need to pop much in and you'll get a nice drop down. If you don't see anything that sort of looks like what you want, immunisation, let's try that. So you'll find lots and lots of different types, different things that come up. Immunisations, I'm not going to go that way. I'm going to pop in because I want to be able to show you a few other things as we go. So as I say, I happen to know that this is where the immunisation suite is kept. Navigating around Health Pathways should be nice and simple and fairly intuitive. Sometimes it's hard. I've been using this as a resource for a decade, and it is sometimes tricky to know what is intuitive and what's not. It is built to be a really intuitive platform. This is our little suite, and it is only a small suite at the moment of immunisation pathways. And it's a really nice way of presenting a lot of the information that we need quickly around immunisation in various populations. So, for example, if we pop in here to our adult immunisation pathway, most Health Pathways, when you jump into them, will look fairly standard. There's a couple of things I do want to point out, though, really specifically within immunisation related to what we're hearing tonight and related to our LHD, our PHN area. The first thing Nick touched on a few times is the fact that our First Nations populations are lagging behind in vaccination rates. And that's certainly true across our area here. It's definitely a high priority on our PHU's radar. And wherever you see this little symbol of the Aboriginal and the Torres Strait Islander flags, you know that there's content in this pathway that's really relevant to Aboriginal, Torres Strait Islander patients, or for our First Nations populations. So that's always a good just thing to keep in the back of your mind. I'll just point out that the way that Health Pathways are built, they really want to build them so that they can be usable and be accurate and be up to date. And sometimes we've got clinical situations where we've got policies that are changing, guidance that's not quite clear, things that are happening at the speed that with where that we're using them. And that's not always easy to capture in our formalised health pathways. However, it's still important to note. So, for example, the evolution of the RSV vaccines is one really great area, as is the evolution of the shingles vaccines. Here in our adult immunisation pathway, we've actually captured both of those issues here in the clinical editor's note at the very top of the page. This is new information. It's information that either might change your clinical practice, might be really important to know today. This might actually be why you're coming to the health pathways. It's here. We've either not had a chance to formalise it into the pathway, or it might be our pathways come from different sources. They're written in different ways. It might be that we don't actually own the pathway. We've got to wait for someone else to update theirs so ours can be updated, whatever it might be. But we still want that information to be readily available. There it is at the clinical editor's note up front, up at the top of the page, so you can see it. That might even be why you're coming to this health pathway today. The other thing that we use our clinical notes for is something that might be locally appropriate. You know, here in Western New South Wales, we know we've been a JE area. So in our clinical editor's note, I've made sure that we've kept the little flag that we are a JE area, so that, you know, if you're new to the area, you're not quite sure, that is there and flagged for you. Otherwise, most of our health pathways will follow a fairly similar layout where you've got any other clinical warnings coming up nice and high for you. And they're designed to be used within the construct, within a consult, so that it helps your consult actually flow. Now, obviously, I'm not going to go through the whole thing. There's heaps and heaps of information here. We actually, since I've last even looked at this, the RSV information has actually been updated into the health pathway since I last checked, which is great. That's how quickly, you know, we do try and keep these up to date as much as we can. And there's a heap of information there, both about the clinical picture that might be in front of you, whatever it might be, and then actions to take as GPs, really designed to support best practice clinical care at the, you know, with the patient in the room with you. I'm going to pop up here just to show you. We've also got some really useful tools. You know, Nick mentioned adverse events, especially really important if you're giving one of the new vaccines. If you're not quite sure, we want to know, well, what's an adverse event? This is lifted almost directly from the immunisation handbook, but really usefully, you can come through. You've got all your little pop-ups that you might wish to use that will direct you to the page. You know, be it a checklist, be it a list of vaccine side effects. And very helpfully, when it's time to report it to the public health unit, it's got your information there for our local public health unit. So all that information is kept there. It really is a one-stop shop of all the information you're likely to need with a patient in front of you. In terms of, you know, you might want to know a bit more about some of the vaccines. I happen to, you know, unfortunately, we've only got the influenza immunisation page localised at this point in time. If you come to a page and you see this bright yellow banner at the top saying page not yet adapted for Western New South Wales, that means this is still the baseline New Zealand information. It won't necessarily be incorrect. It just might not be right for our region, and it may not be helpful. We are working to get as much of this localised as possible, but I couldn't give you a timeline, and there's lots and lots of factors as to how we choose, you know, what we work on next, why we choose certain pages, why we don't do certain pages. What I do want to say though is, if you find a page that you keep coming to over and over and over again that's not been localized, and you think, gosh, you know, especially listening to that information about all the new pneumococcal vaccines that are coming, you know, this might become a page that you come to once a week and you go, gee, Amanda, can you please update this? I really need this. Jump down here, send us some feedback, let us know. We do get some stats about what pages people are looking at, but actually it's really powerful if we can actually say, gee, we've had, you know, 50 requests this month to localise the pneumococcal vaccination page. Maybe we should see if we can prioritise that. So please make sure you send us feedback. Likewise, if you read something in a health pathway and you think, oh, that's last year's news. Or actually, I've just been to this talk by Nick and he actually said this other thing. Can you please fact check this? Please jump on, send us some feedback. We've got, we've got some really great systems that allow us to get that feedback very quickly, and we prioritize managing any feedback, especially feedback around clinical concerns or issues. The other thing that you might notice here is that this is not a very long list of vaccines compared to the number of vaccines. Someone this evening mentioned Q fever. We've had COVID mentioned a few times. So yeah, Audrey, I don't see COVID vaccine there. I don't see Q fever vaccine there. Well, you can pop up here and again, do your search, COVID immunisation, and I do apologise that the language isn't consistent. It's that there's a couple of reasons for that. I do apologise. It's annoying, but please bear with us. The pages don't all. We don't work with all the pages in the same way. So that is why sometimes you'll see us use the term immunisation or vaccination. But you've decided you want some information about COVID immunisation. Pop that in your search and you go, oh, well, there is some information there. It just happens to be stored in a different part of health pathways. It might seem a bit counterintuitive that we've got a COVID-19 vaccination page that's not stored with the rest of the vaccinations. And again, there's some background reasons for that. We will, wherever possible, try and link it back into, try and pop a link. It's not always possible, but just know that if you're looking for something, it isn't where you think it should be. Make sure you do have a search, because sometimes things aren't exactly where you think they should be. Same with Q fever. I don't know if it's up as yet, but there will be a Q fever. There will be a Q fever page coming soon. If it looks like it's not there as yet, but there will be a Q fever vaccine page coming soon. I think that's really probably enough of a whistle-stop tour for health pathways. We are really keen to hear your feedback. We're really keen to hear what you like about it. We're also keen to hear what pathways you feel are missing as a priority, and why. Obviously, we can't prioritise everything. We'd really love to. But please have a low threshold for dropping us a line, and certainly, in creating these pathways, we do work closely with local subject matter experts. So we had the local public health unit involved with localising these pathways, and so that they are a really great resource. So that's probably enough from me.
Thank you, Amanda. That was great. I'm just asking everyone if they could just do the evaluation for us tonight before you leave. Again, thank you, Amanda, and thank you, Nick, for your wonderful updates with everything, and thank you all for joining tonight. I'll just leave this up for a minute before can you see that? Sorry, I didn't share. There we go.
Wonderful. Thank you all so much.